Okay, so we'll move on to the next talk, who also Fasiha will give us to us. And it's about DAA pharmacology, side effects and drug interactions in HIV and post-liver transplant patients, reactivation of hepatitis B virus. So this is something which we're coming up with many questions, and who better than Fasiha to tell us about the items.
So, all right. I will probably have more questions than you guys, and here to learn from you on this topic as well. I have a little disclaimer. I do not do liver transplant care very much now, since moving on to other administrative responsibilities. So I'm here to learn from you. But because I was assigned to present, I'm going to present. All right. So this is, I just created this slide after hearing what Mauricio, or pretending to figure out what Mauricio was trying to say, guessing. So my overview slide is right here. And then I have a conclusion slide too. I think that's what you said, Mauricio, right?
You're doing great.
Excellent, excellent. I'm learning very fast. So I'm going to skip through several things because we are running behind, so hopefully it will get us back on track in terms of time as well. But that was sort of the thing that I wanted to talk about. You all know all the DAs. I am assuming that most of the new DAs are available here. You also know where they are in terms of what they do and how they work. So that is something that I'm also happy to share the slide sets with you separately as later on as well. So I will not spend a lot of time here, but I'll go on to talk about, if I can move through it, here, the HIV HCV co-infection, because that was one of the high-risk groups that I was asked to talk about. So Ray, are you covering the co-infection as well tomorrow? Okay, so maybe I can talk about that and then skip through the transplant part? Okay, no. I'll just do that, and then I'll skip the liver transplant completely. So HIV, HCV co-infection, how many of the people in the group take care of co-infected patients? So it's a special population. Do you think that these patients should be treated for hepatitis C virus infection? Yeah. So, and there are many reasons that this population should be treated. One of the reasons that hepatitis C is actually quite common in these patients. Different studies quote numbers from 15 to 30% of HIV-infected patients also have hepatitis C virus infection. And the problem is they actually, compared to just the mono-infected HCV population alone, which in itself is at a high risk for many complications, though that risk of complications is much higher in the co-infected group. So if any group needs to be treated, that is the group that needs to be treated. And here are some data showing from a study from a few years ago that looked at over 4,000 patients who had co-infection who were already on antiretroviral therapy, so that HIV was controlled. And they compared that to about 6,000 patients who had HCV monoinfection, so alone. The darker black line is the co-infected patients where the HIV was under control, and the red line is the patients who have HCV monoinfection, and the picture tells the story. So for up to 10 years of follow-up, the patients who were co-infected had a higher risk of having liver complications. I'm just showing you the graph for decompensation, but it's a similar story when you look at liver-related mortality as well. So this group has a higher risk of having liver complications than patients who are mono-infected, and that is why this group needs to be treated. The problem has been, despite this high priority, is that we had significant difficulty treating HCV mono-infected patients. The difficulty was even larger for co-infected patients with interferon. And the reason was the response rates were really bad in co-infected patients with interferon. Patients had many comorbidities that made it harder to treat those patients, and there were significant side effects, just like as in the HCV mono-infected patients. So not a lot of co-infected patients got treated with the previous interferon-based era, but things are different with the new DAAs. There are many studies that have now shown that DAAs work as well in co-infected patients as in mono-infected patients. They're safe, easy to take, and they should be given to patients with co-infection. There is one problem, though, and that is what you wanted me to focus on. But before that, I'm showing you some data. These are actually data from what we were earlier referring to as a real-world effectiveness study. So this is a large study that was just published recently. It's a large group of patients with co-infection that got treated with all the different DAs in different clinics, different hospitals. And you can see the size, the length, the height of the graph. All across is 90%, no matter what treatment they received. These are co-infected patients. And also, it didn't really matter if they had any other issues. So cirrhosis, as you know, is a major issue for co-infection as well, though their risk rate of SVR was a little bit lower, but still was pretty high. About 80% of patients with co-infection and cirrhosis were cured, and it was about 90% if cirrhosis wasn't there. So all across, it does work in patients with co-infection, and there is not much reason to withhold treatment from them except for this issue. The issue is with drug and drug interactions. It has always been an issue with HIV medications. Luckily, we didn't have to deal with it ourselves. Our infectious disease colleagues and primary care colleagues, they did it. But that, with the new DAAs, there are significant and complex drug-to-drug interactions between the two types of drugs. And sometimes they do require change in the HIV treatment. The regimen might have to be changed based upon the potential of that interaction with the treatment that we are planning for the DAAs. And this has led to what I think a better collaboration between HIV and doctors and hepatologists, just because it has to be done in collaboration and in partnership with each other. There are several reasons why we see these drug interactions. I've listed them right there. Many of these drugs, they serve as substrates for the cytochrome P450 that we all learned about in biochemistry, and several other transporters that are involved in the drug metabolism. And one effects on those important molecules, it changes how the other drug is metabolized. And that is why we see these things. It could be either the suppression or it could be the induction. So it could go up or down, and it's variable which drug you're looking at. So I'm going to give you a few examples of the most common things that you might see, and then give you a little reference that I thought was really useful, because I don't think I can keep up with this myself, at least. So with this treatment, with the significant P450 inhibition happens with the ritonavir, and this combination, anything that is metabolized by P450, the levels of that drug can be increased. So with Viekira, that is something to think about. It has several drug interactions with several HIV medications. The cladosphere, it is a substrate for cytochrome P3A. And when it is given with any other drug that works with the same, with the cytochrome P3A, the cladosphere's drug levels can go up and down. So it doesn't affect the HIV medications. The HIV medications can affect its own level. So you have to go up or go down, depending on which drug you're using. And it depends on the drug. It could be inhibition or it could be induction. This is a very common regimen that we use, ledipasvir and sofosbuvir. And as it is, it's not really a substrate. It is a substrate for P-glycoprotein, just the ledipasvir part. And the only major drug reaction is with tenofovir. I don't know if anyone has used it with tenofovir, but there is a concern that with this combination, tenofovir levels can be out of range. And there is some concern that it can even cause renal toxicity. So if patients are on both combinations, they have to be watched very carefully. And anyone who has the creatinine clearance of less than 60, they should not be given this medication. But as I said, it is just way too much to remember. So I've listed just some of this here. I personally will not say that I remember all of these things. I just remember those 3 things that I told you about. But this is the list of the drugs that can have a drug-to-drug interaction with when you're using these 2 different classes for patients with co-infection. But this, what I found useful was this. So I'm not so sure how many of you are aware of the Liverpool HIV and hepatitis pharmacology group and the database that they maintain. 1, 2, 3, 4. So this is a very user-friendly program. It's on the web, and it's pretty accurate. This is a screenshot that I just pulled. You go in and you put on the medications that you are considering for the patients for the hepatitis C virus treatment and also for HIV. And within a second, it will tell you if there is an interaction concern or no. And I think this is probably the only take-home message that I have for you in this talk.
In addition, it gives you colors.
Yeah.
So then you define red or amber or green, and you can print it out and put it in your file if you wish, or share it with
Share it with the patient. So that's my next slide. So it gives you a color-coded scheme that actually you can hand out to the patient as well. So I was just playing with it. So here, these 2 medications I just picked up, and there's no significant interaction between the 2. And you can pick many on both sides, and it will give you the information. So that, I think, is, God bless these people who did that, but that, I think, is very clinically useful at the point of care. So that's the message, the most important point. The second point that I wanted to make is that I think with these complex patients, it is important to work in collaboration with someone who takes care of HIV. And that, I think, is also as important as anything else, not only because you have to watch out for the drug interactions, but because their HIV regimen might have to be changed. We don't want to withhold treatment for anyone. We really want to make sure everyone gets treated. And for that to happen, the HIV medication might have to be changed, which is a big deal for these patients, especially those who have been on these treatments for a long time and where the HIV is under control. Just imagine about switching the HIV medication. It's a high-risk decision, and sometimes it might be necessary, and it is necessary to change the HIV medication, in which case they have to be monitored very carefully for the HIV, make sure that they're still suppressed. And the recommendation is to check it every 4 to 8 weeks to make sure that the viral load is under suppression. And after the hepatitis C treatment is completed, the recommendation is to continue with the new HIV treatment for at least 2 to 4 weeks because of the drug's half-life for the DAAs. So you want to make sure that that is completely gone before the patient is switched back to the previous HIV treatment regimen. So given that, the second point that I wanted to remember is to just go ahead and call your HIV specialist friend and make sure the patient is being seen by him or her as well. This is the third take-home point, hepatitis B virus reactivation. So I'm sure many of you in the room have heard about this issue. It has been in the news and got a lot of press coverage as well. It happens. It is real, but I think the alarm is a little bit higher, greater magnitude than what really we are seeing. So here is an FDA report that came with the warning of they saw 29 cases, 5 of them were within the US, of hepatitis B reactivation with the DAAs. There have been several studies that have come after that, also showing that yes, it can happen, but it happens in a specific patient population. And based on that, the recommendations from the AASLD, along with the Infectious Disease Society, are here. So the recommendations are for hepatitis B, and these are for everyone who is on DAA, not just the co-infected patients. This is for everyone with hepatitis C virus infection. If the patients have active hepatitis B, meaning they have hepatitis B surface antigen is positive, so that's the most important thing. And if they're not on hepatitis B medication, that is, you have to monitor their hepatitis B DNA during and immediately after DAA therapy, and treatment should be given to patients if they meet criteria for hepatitis B treatment. So it is important. It does not mean that you have to right away start the patient on hepatitis B medication, but that patient has to be watched. Based on the guideline, they still have to meet criteria for hepatitis B treatment before they need to be started on the therapy, additional therapy. There was quite a bit of concern that patients who had just the core positive, not the surface antigen, that their risk might be higher, but other studies have shown that's not the case. Most of the time, the cases of reactivation happen in patients who are surface antigen positive. So I think this is an important thing to take home, and this applies to the mono-infected patients. What about the co-infected patients? So first of all, anyone who has HIV and hepatitis C should be tested for hepatitis B. It's not a new guideline. This has been there in the HIV guidelines forever. So anyone who has hepatitis, HIV and hepatitis C should be tested for hepatitis B, nothing new about it. And patients who have hepatitis B infection, in this case, just surface antigen positive, they should then be started on hepatitis B medication, along with antiretroviral therapy, and most of the time these patients would be on tenofovir. So the little difference here is that in the HIV guidelines, they're recommending starting patients without waiting for them to really meet the criteria for hepatitis B virus treatment. For patients who are only core positive, we just have to monitor them. For them, they have to be monitored and they don't have to be started on the treatment. I'm going to skip that part and go right to the end here. So in summary, we talked about all these interactions, talked about how we have to manage this patient population, but the bottom line is these patients need treatment and they should get treatment. There are many resources, many treatment options that we have, that our infectious disease colleagues have. So almost every patient with co-infection is eligible for and should get treated for hepatitis C virus infection. It is important to work with somebody that you can talk to and collaborate with for the patient for this patient subgroup. And then yes, they have to be watched for potential interactions. I'm not going to talk about the liver transplant patients. Leave this topic for tomorrow. But I will take any questions that you have and try to answer them.
Thank you very much for your talk. I just have a question. When you check on the Liverpool page, there are some few that don't appear there. So, for instance, epamers. I was just looking at right now in Hippocrates, and in Hippocrates says there is no interaction. But if you don't find any interaction, do you use them confidently? Do you also, Mauricio and Dr.
So I'll let Mauricio take that question.
90%, or when I say 90%, I'm just debating the percentage. I think that close to 100% of those medications have a lot of information. There are two drugs in the HIV world that I'm always worried. One is the Fabrins, and the other one is called the Cystec. And those are the two that worry me the most. And the other, quite honestly, I use Liverpool. But in the U.S., we have pharmacists that work with us constantly, and those guys have databases that are deeper than the ones that I use, and I do trust what they say.
There are very few of them, but there are some that don't appear there.
Right. There's also another resource. It was just too much to put in the presentation. Both AASLD, they have a very large, nice table with all the medications and different interactions. HIV, AIDS guidelines, they have those tables as well. And they are quite comprehensive. I haven't checked if they have 100% of the medications, but just to glance through it, I found most of them there. So those could be additional resources too.
Thank you.
I would like to ask about what you can tell me about the immune response, because you can see the reactivation of hepatitis B, and also it's have shown in herpes virus also. And it's supposed that the NK cells are suppressed, the activation of the NK cells are decreased, and it can increase the risk of tumorigenesis or carcinogenesis. What can you tell me about the immune response and the natural killer cells?
Not very much. Sorry. I'll have to come and read about the natural killer cells and come back and tell you, but I do not have an answer right now. All right, thank you very much again. It's a pleasure meeting you all.
Very much. We are very pleased, and we'll give you something that Ray has with him, and we're honored to have you remember the association with this scarf, which is made of the association. Thank you.